Good afternoon. This is Kim McCleary. I'm President and CEO of the CFIDS Association of America. And my first hope today is that everybody who's logged on can hear me. We had originally planned to do this webinar last Thursday, and due to some audio system problems with GoToWebinar, we weren't able to carry out those plans. And Dr. Lewis Katz, our speaker today, graciously was available to us to reschedule for this afternoon. So I hope that the sound is coming through and that the recording is taking, and that otherwise all technical systems are go. This is the 11th webinar in our 2010 series, and today's topic is XMRV and blood safety. And we're delighted to have Dr. Lewis Katz, the Executive Vice President of the Medical Affairs Mississippi Valley Regional Blood Center with us. I will give a formal introduction of him in just a couple of moments after going through some housekeeping measures. We had about 300 people register for today's program, and just about 80% of them have participated in a past webinar, so I don't need to spend too much time on housekeeping, but for the benefit of those who are joining us for the first time on one of these webinars, I did just want to give a couple of quick pointers. First of all, Dr. Katz and I are in different locations. He's out in Iowa. I'm in Charlotte, North Carolina, so we can't see one another. We can't see you, and you can't see us. All we can see together are the slides that are being projected on the screen. So we don't have the benefit of nonverbal cues, and we can't kick each other under a table. So just please bear with us as we perhaps have to kind of have a conversation with one another about the control panel and how to do certain things with our slides. The questions that were submitted through the registration process were shared with Dr. Katz in advance, and we'll start our question and answer session that follows the presentation with some of those questions that came in. If you do have questions as we're going through, please type those in. There's a dialog box on the right-hand side of your screen with a little question bubble. Just type those in as we go, and I will collect those and kind of triage them and then share them with Dr. Katz in a conversation after he finishes his slides. We are recording this, and hopefully, as I said, the recording will take, if you will, and we will post it on our YouTube channel at Solve CFS within a couple of days' time. It takes a little bit of time for the recording to process, and then we'll post that up and include the URLs in an email that we send as a follow-up to today. Finally, although Dr. Katz is an MD, this format really is not appropriate to have him address individuals' questions about their symptoms, their diagnosis, or their treatment. So we're going to exclude those types of questions from our Q&A session. The only other topic that is really not appropriate to today's program is the discussion of data about XMRV or CFS that have not yet been published. So we'll just go ahead and take that off the table before we get started. As I indicated in kind of my introductory remarks, our speaker today is Dr. Louis Katz. Dr. Katz is a physician. He's trained in infectious diseases and did his training at the University of Iowa College of Medicine. He's certified in both internal medicine and infectious diseases, and was telling me last week when we were together for our what I'll call our practice run, that he began seeing CFS cases in the mid-1980s and found that many of the patients that he saw in his clinic had unusual EBV serology. And so he's been following this condition and the research and the literature on it for quite a while, and of course the latest studies associating XMRV and CFS have certainly brought his attention in a different direction in his work with the Mississippi Valley Regional Blood Center and through his work in various leadership capacities with America's Blood Centers, the AABB, which stands for the American Association of Blood Banks, and on service for committees like the FDA's Blood Products Advisory Committee that met just a couple of weeks ago in Gaithersburg, Maryland, and spent about half a day of its time together on the topic of XMRV and CFS. So we're delighted to have Dr. Katz here this afternoon. He's one of the premier experts in the topic of blood safety and transfusion medicine. And I know that I, along with the couple of hundred people we've got registered today, are looking forward to his slides, so I won't delay any longer. And now, Louie, I'm going to switch the controls over to you and let you take it away.
All right, let's see if it works. I can see it. Can you?
Yes, I can.
All right. Well, as Kim told you, I have professional interest in blood safety as it relates to infectious diseases. And my title slide here is just a graphic illustration of kind of where we are right now with XMRV. We struggle in transfusion safety with assessments of risk versus benefit, primarily around how much safety can we have and still have a robust blood supply for transfusions to all the people who need transfusions, whether cancer and transplant patients, trauma patients, surgical patients, etc. So particularly early in the discussion of an individual infectious disease, before we have a good handle on the causal relationship of a bug to a syndrome and the transmissibility by transfusion, we frequently find ourselves going both ways. And so forgive me if I can't give you all the answers you want today. This is a summary of kind of what I'm going to tell you about XMRV specifically. While there are associations described in the literature of XMRV, not just with chronic fatigue syndrome, but also with prostate cancer, that's different than any proof of causality, and that's really a critical issue. And then beyond that, is it everybody who would be susceptible to disease causation who got infected with an organism, or only a distinct population? There are data that do indeed link XMRV to chronic fatigue syndrome. There are a number of studies, I'm sure you're aware, that have been unable to confirm that association. So at the end of the day, our real posture right now is that we need to get the work done that's required to either associate or refute the association of XMRV with chronic fatigue syndrome, prostate cancer, or anything else. Now, asking for more work isn't the same as saying we can't do anything, and I'll get into that later on in my talk. First, I want to describe to you the U.S. blood supply and what we're currently doing to ensure safety from recognized transfusion transmissible diseases. And then I want to go into the performance characteristics that we demand of our tests and why, and then I'll get more specifically into what's going on with XMRV in the blood community after that. So the U.S. blood supply is essentially all volunteer. This is not plasma derivatives like intravenous immune globulin or albumin, but transfusible blood products, red cells, platelets, plasma, cryoprecipitate, those sorts of things that are made from live donors and that can't be sterilized. There are about 15 million, 16 million red cells transfused, and 4 million platelet doses a year in the U.S. These are provided by 73 independent, not-for-profit community blood centers that are members of America's Blood Centers. That's about half. The American Red Cross Biomedical Services, distinct from disaster services, about 45% from 36 blood regions. And then the remaining 5 or 7 or 8% are from hospitals and unaffiliated community blood centers. We get regulations, essentially laws, from the FDA that tell us what we must do, and standards from the American Association of Blood Banks, AABB. We consider, and I think everybody in the blood community considers, the regs and the standards to be the minimum that we must do to protect transfusion safety. Any individual organization has very wide latitude to do more than what's required in the regs and the standards, as long as they don't make unfounded safety claims. So look at the regs and the standards as the minimum that we must do. In order to qualify a donor, we basically have 5 things that we think are important for protecting safety. The first is how we recruit a donor. That is, when we ask a donor to be a donor, to become a donor, they need a certain amount of education up front about what constitutes a safe donor, and have the opportunity at that point, without telling us anything, to remove themselves from our call lists or as a potential donor. Once a donor has been recruited and actually comes to the blood center or mobile blood drive, they undergo an interview that at minimum is 48 items on the Universal Donor History Questionnaire, which is used in most venues these days. Some centers have additional questions beyond that 48. Those of you who have been blood donors or who have friends and loved ones who are blood donors know that we get fairly intimate about things like sexual history, sexual behaviors, drug use, that sort of thing. It's a fairly personal interview and is, we think, effective at reducing the number of donors with transfusion transmissible infections who actually get to the donor chair and get a needle stuck in their arm. In addition, we do a physical exam that's designed to be sure the donor is healthy on the day of donation, and quite specifically to look for stigmata of injection drug use. We check a hemoglobin to be sure that the patient has enough red blood cells to donate, and then once a unit is collected, it goes back to the laboratories for in vitro blood tests for a variety of things, and I think I'll show you that list in a subsequent slide. Who can donate blood? You don't have to pay attention to the numbers or the calculation on this slide. What the point here that I'm making is if there's 300 million U.S. residents, 100 million, slightly over 100 million, or about 38%, are in fact estimated to be eligible to donate blood, and only about 12% of those actually do. And the reason that I bring this up is to begin to put it in perspective the tension that we deal with on a daily basis in the blood community with regards to how many people can we defer for how much safety versus how many people do we need in order to provide the components that so much of medical care depends on these days. These are the infectious disease tests that we do. So you can see here that in the broadest terms there's 14. Syphilis, hepatitis B with 2 tests, HIV groups 1, 2, and the outlier group, HTLV, human T lymphotropic retrovirus, hepatitis C virus, and T. cruzi, Trypanosoma cruzi, the agent of American trypanosomiasis or Chagas disease. We also do nucleic acid testing. The column on the left is serologic testing. It's the old-time detect an antibody or a protein of the virus. They have some drawbacks in that they turn positive in general within weeks, not days, after a person becomes infected. As a result of that observation of what we call the serologic window through which an early infection can sneak, in 1999 we began doing nucleic acid testing, primarily PCR and transcription-mediated amplification for people who are interested in. And we look for all the HIV groups, hepatitis C, hepatitis B, West Nile virus, parvovirus B19, the 5th disease virus, and we think, we know that hepatitis A testing will be coming, we think in the near future, particularly for donors whose plasma gets sent off for derivative manufacture, and quite high on our radar right now is dengue. You may have heard of autochthonous dengue occurring in Florida recently, and huge outbreaks in the Caribbean, South America, and large parts of the tropical world. And we're also discussing babesiosis, which is hyperendemic in about 7 states in the United States. So the menu is substantial. These tests have to be completed, the blood labelable, and on its way out to the hospitals essentially within 24 hours. So it's a substantial amount of testing in our high throughput laboratories. I'm not going to spend a lot of time on test performance jargon, but I want folks to understand the unusual constraints under which we operate in blood banking. The quality of the tests that we need is far higher than the usual diagnostic studies that you get if you go to your local laboratory or your doctor orders a test for this, that, and the other thing that you might be interested in during a physical examination or evaluation of symptoms. And these are the possible outcomes on a test. True positive means if you have what we're looking for, your test is positive. True negative means if you don't have what we're looking for, the test is negative. But then we have two other categories, false positives and false negatives. And they're self-explanatory. These slides will be available to you, I believe, and you can think about the definitions in more detail later on. When we use these four definitions then, we define four performance characteristics of a test. Sensitivity, which is the ability to find people who have what you're looking for. Specificity, which is our ability to miss people who don't have it. And then positive and negative predictive values. And these are the two. These last two are the important ones. Positive predictive value is the likelihood that if I have a positive test on either a patient or a blood donor, that the result is correct. And negative predictive value is the converse of that, the likelihood that a negative test, in fact, is in somebody that doesn't have the infection we're looking at. The next slide shows you the performance of a blood donor screening assay in my blood center during 2009. And it's the center outlined in yellow that's most important. This is the predictive value of a positive HIV test in a blood center. Okay? So if I have 200 and, excuse me, a population of 100,000 blood donors, with the performance of the tests that we use, I know that 60 of those 100,000 blood donors are in fact going to be false positives. If I then look at how many blood donors, after all the interviewing that we do, actually have HIV, we find that under 2% of the donors with a positive HIV screening assay tested in my laboratory actually have HIV. And those donors have to be counseled about the meaning of a false positive test. And if any of you have been notified as donors of false positive tests, you know how emotionally and intellectually difficult that can be. As a result, we need screening tests with remarkable performance characteristics, minimizing both false positives and false negatives, and we need confirmatory assays. And the confirmatory assays are designed to be able to give the donor who's been deferred because the screening test was reactive the right answer and proper counseling. So we don't talk about developing just one test when we begin to discuss donor screening assays. We need both remarkably sensitive and specific donor screening assays and confirmatory assays that ultimately allow us to get to the right answer, so that when we talk to the donor who's had screening reactivity, they understand what are the implications or lack of implications, particularly of false positives, for their health. Okay, well, you guys know as much about chronic fatigue syndrome, I guess, as I do, but it's been my experience in 30 years of taking care of patients that the more names we have for a clinical syndrome, the less sure we are about what's going on. And I don't think, in fact, that there is any syndrome that I dealt with regularly in my clinical practice prior to my retirement from clinical care last year. I don't think there's any syndrome that has been, over a period of 25, 30 years, more confusing than CFS, CFIDS, myalgic encephalomyelitis, or whichever name we're giving it these days. The bottom one, the sixth one on this, is, I believe, was proposed by the workers at Whitmore-Peterson Institute after their description of the putative association of XMRV with chronic fatigue syndrome. Well, the epidemiology you should be familiar with. If the prevalence is actually 0.4 to 1% in the U.S., that means up to 4 million individuals who have CFS. More females than males, more whites than others, although the epidemiology is fraught with complications with regards to how one makes the diagnosis and how much access to care, expertise, and evaluation an individual patient has. At any rate, when you start talking about 1.2 to 4 as a reasonable range in the U.S., it's a substantial issue. The pathogenesis or how this disease is caused, I think the number of names reflects our lack of understanding. These are some of the things that have been proposed, and I'm not going to go into these in any detail, but this is essentially the breadth of medical practice, immunologic, hormonal, neurochemical, psychological, infectious, toxic, and other triggers are all discussed. For those of you who are interested, reference at the bottom of this slide is a superb explication of what we think we know about how CFS comes about. This slide is not for you to internalize in any data-driven sort of way, but just to remind me to move our understanding of pathogenesis forward a little bit in time. And this is a study that was published in the Journal of Infectious Diseases a couple of years ago, and it basically looked at what genes are turned on and off in chronic fatigue patients versus a control group of normal blood donors. And the point of the study was that there are a number of genes that are expressed differently in the patients than in the controls. And as you read further into the paper, you find that they tend to cluster into patterns consistent with disease of the hematologic system, consistent with expression profile seen in patients with cancer, consistent with profile seen in people with autoimmune disease, and several other clusters. And I think that really leads me to the way that I'm looking at chronic fatigue syndrome over the last decade or so. And the real question here, I think, is whether chronic fatigue syndrome or subsets of chronic fatigue syndrome represent discrete diagnoses and pathologic entities as opposed to just a debilitating but nonspecific response to a very wide variety of stimuli. My guess is that there are going to be a large handful of causal relationships or pathogenic relationships described over time, and that each individual grouping that we manage to sort out over time will have implications, a different set of implications for how we diagnose and treat that group of patients. So if XMRV is in fact causally associated with CFS, I think it's highly unlikely it will be everyone in the diagnostic category, and that we'll still be looking after we sort out XMRV for some large subset that remains that is likely unexplained. That's my opinion. The data can't prove me wrong just yet, so I can keep saying that until we know more. Okay, so let's get to XMRV itself. XMRV is Xenotropic Murine Leukemia virus-related virus, XMRV. I don't want to say the real name again, so I'll say XMRV. It's in the group called gammaretroviruses, and these viruses, we know, can cause leukemias in rodents, felines, primates, a number of animals. Also some neurologic diseases, other tumors and whatnot, but primarily were recognized as leukemia viruses. The xenotropic murine leukemia viruses are what we think are mouse viruses, or what started as mouse viruses. They can be isolated from the chromosomes of inbred and wild mice, but will grow in non-rodent cells with the potential to infect lots of different animals, including humans. XMRV is very closely related to the xenotropic MLVs, and recent studies, first in prostate cancer and subsequently in CFS, have suggested that people with CFS and prostate cancer have more evidence of XMRV infection than healthy controls. So then we're often running with not only is there association, but is there a causal relationship? And you should be familiar with the Lombardi paper from Science last fall. Here's a picture of XMRV in the title of the paper. And this is kind of a summary. Evidence of XMRV was found in 67% of the CFS patients, and the WPI people have subsequently increased that number to, I think, over 90%. The strength of this paper was that they used multiple different ways to look for evidence of infection. So they looked for the viral genetic material, they looked for expression of proteins, they looked for an antibody response, and they looked for the ability of blood and body fluids from CFS patients to transmit the virus to cell culture. And as I say, in aggregate, 67% of the patients had some evidence of infection with XMRV. The thing that was most important to those of us in the blood community, and that caught our eye literally the day that it was published online, was that they were able to find evidence of XMRV DNA in 3.7% of their healthy controls. So as I told you, we're producing about 20 million, it's actually more than 20 million components a year from about 7 to 10 million donors. 3.7% of 7 to 10 million is a big number if, in fact, well controls are infected at that rate and the virus causes disease. There were a couple of perspectives or commentaries that accompanied the article, and I just give you this one quote from one of them. Given that infectious virus is present in plasma and blood cells, blood-borne transmission is a possibility. This is true also of HIV, the causative agent of the acquired immune deficiency syndrome, and HTLV 1 and 2, which are associated with an unusual form of leukemia and some neurologic syndromes in a few individuals who are infected with that virus or those viruses. Well, so here we are. Subsequent to the Whitmore-Peterson Institute publication, we've had the publication of 3 studies, 4 actually, looking specifically at cohorts with chronic fatigue syndrome. And we're trying in the blood community now and in the research community in general to try and figure out how to interpret 2 sets of data that look really different. WPI found 67% and now a higher number. The CDC, a group in the Netherlands, and 2 independent groups in the United Kingdom found no evidence of XMRV in their chronic fatigue cohorts whatsoever, and we're trying to figure out how to balance those 2 things. Now, I'm not going to go into data that's unpublished, but there is another elephant in the room, and I'm sure you've all heard of it. Got a lot of publicity after one of the co-investigators, Harvey Alter, discussed briefly at a meeting in Zagreb, Croatia, in May at a virology meeting in Zagreb, that investigators at NIH and the FDA had data that tend to confirm the findings of the WPI. You probably subsequently heard of the controversy. The publication in PNAS was held up in order for the investigators to complete some confirmatory studies. I can only tell you that the rumor mill tells us that that paper will be published imminently in the Proceedings of the National Academy of Sciences. We await it anxiously in the blood community. Some of the co-investigators are very well established and highly respected investigators who have been pivotal and very important issues to the blood community over decades. And when it comes out, we believe it's going to be on the WPI side, but stay tuned on that issue. Okay. Other populations have been looked at, and Kim and I were discussing before we went live for the program today. We're kind of getting a headache trying to keep up. But there are populations that are sentinel populations for bloodborne pathogens, and certainly nobody more so than HIV. And this AIDS, journal AIDS study that Kunzman's study at the top, was unable to find XMRV in HIV-infected patients and controls from the Chicago Multi-Center AIDS Cohort study. And then you can see others in blood donors using a GenProbe, that's a company, using their assay, and they were unable to find it. And there are more and more coming. So that's where we are. Nu is Yiddish. It kind of means what's going on here, as simply translated as I can. Why do we have cohorts of people, many of whom defined using the same definition of CFS, and we're getting distinct and different answers? And some of the explanations that have been discussed and may well play out as time goes on are here. Maybe the clinical populations aren't the same. Maybe the application of diagnostic criteria or the diagnostic criteria used are different enough that we get different answers from the different populations in the various studies. Perhaps the virus detected by WPI is prevalent where they looked but not in other places. Maybe there's strain variation, and this is particularly important when we use DNA-based testing. Because if the sequence of bases making up the DNA is different, our ability to detect them with different test methods will be different. There are all kinds of controversies about the methods used, the controls used, whether the tests being used in the negative study are sensitive enough, whether the tests are specific enough, that is, the ability to miss people who don't have what you're looking for is adequate. In some studies, the investigators are blinded, and others they aren't. And DNA-based assays are extraordinarily sensitive to contamination in the laboratory. And all this stuff remains to be dissected as the research goes forward. My suspicion is it's going to be all of the above and probably some things we haven't thought about. And my fallback position is that this is gremlins or Dybbuk's, malicious spirits, making it hard to get to the right answer as fast as we would like. So our key issues remaining, as I get into the actual blood community response, are shown here. First of all, is there really a disease association, or is this somehow confounded by how we've selected and tested the samples? We need to, if we think this is a real threat, establish how it's transmitted. We really have no idea at this point. Where does it go when it gets into humans? What tissues get involved? So how can we prepare ourselves to look for clinical manifestations we haven't thought about yet? What other human diseases might be involved? And what should our approach to blood donation be? Our approach is, how should they evolve as the understanding of the facts evolves? Well, in order to examine that, there's been a couple of working groups. The first one is from NHLBI under the directorship of Simone Glynn at NHLBI, National Heart, Lung, and Blood Institute. And that's a scientific research group, and essentially the charge on that group, on which I sit, is to figure out comparable assays, understand how various assays perform, then to move on to look at the prevalence of XMRV in blood donors, determine if it's transfusion transmitted, and then figure out if, when it's transfusion transmitted, it results in disease. The importance of that will come up on a later slide when I show you some other viruses they tried to blame us for in the past. Phase 1 is well underway, and it's just designed to compare about 6 labs on their ability to find the same thing in identical samples. And I'm not going to go any further into that activity except to show you that, in fact, here's 6 labs, 2 at the FDA and 4 others, that really are able, in whole blood preparations, at various dilutions of the samples, to find a pretty comparable sensitivity. You want to look at the red bricks here, and as you can see, the lowest or highest dilution at which a positive signal can be obtained are within a couple of dilutions, between 13 and 1.5 basically. So in a whole blood panel, these are assays that really are looking in the very earliest phase of testing reasonably consistent. And then in plasma, same thing, although not quite as sensitive. Retroviruses, gammaretroviruses, tend to be very highly cell-associated, and so we expect plasma to be less sensitive than we expect whole blood to be. Again, the take-home here is, with the exception of the one FDA lab here, pretty consistent sensitivity around, let's say, 100 to 400 copies per mil of plasma. So we're making progress. These are very few replicates of the samples, as you can see. There are 3 to 6 replicates of the samples, and but good news in that some reasonable consistency. So the assay characterization, the test characterization, is moving along. Let's talk about what we're doing now. I think CFIDS Association has been very, very forward-looking for a long period of time with regards to blood donation by people with CFS. And their reason, I think, is the reasoning is very sound, that the likelihood of reactions, the likelihood of feeling worse if you donate blood is quite high, so lay out. And they included in their rationale the fact that there may be unknown viruses. This position comes before XMRV was on our radar screen. So I think this is a really appropriate approach. The real fly in the ointment at this point is if the WPI studies are correct, and almost 4% of the population has it, we don't capture them with this approach. This approach is directed to people with CFS. NCI came out with this statement only after XMRV was alleged to be associated with CFS, but I think their bottom line is correct. Prudence would dictate that potentially infected individuals, that is, with XMRV, refrain from blood donation at this time. I think that's sound advice. From the standpoint of the blood community in the United States, the first question actually on the Uniform Donor History questionnaire is, are you well today? So our donors have to be well, and it's the sense of most of us, and particularly myself, who took care of CFS patients in the clinic for a substantial period of time, that people with active CFS aren't coming in to donate. Doesn't mean haven't, or when recoveries occurred don't, but we think the number of people with active CFS attempting to donate is really quite small. So the second task force is the AABB Interagency Task Force that was charged by the board at AABB to review the data on XMRV, to make recommendations about further action, to assess risk, and propose mitigation strategies if it was appropriate, and develop good messages for donors, the recipient, and the public on what are the risks of XMRV transmission through blood and cellular therapy products. And this panel is chaired by Dr. Harvey Klein, who is the director of the Division of Transfusion at the National Institutes of Health, and a widely respected gray-haired expert on transfusion-transmitted infections worldwide. So the first thing we did was to develop a fact sheet on XMRV. A group of 6 of us a year ago published a long supplement to the journal Transfusion. It was published in August, and it listed 68 bugs that we thought had the potential to cause headaches with regards to transfusion-transmitted infection. And the first new one out of the gate after we published our supplement was not one we had thought about ahead of time. So we're 0 for 1 at this point, I guess. But the Science article was published in November, and we had a fact sheet prepared for the blood community by the first week of January. It's been posted on the website, and you all can get at it. The web address is at the bottom of the slide. It's subsequently in its 3rd revision. I'm not going to go into the details. It's a lot of science, and then our recommendations, which in January was we didn't really know what we could do and that people should stay tuned because the field was going to develop quickly. All right, so where are we? At this point in the blood community, we have no causality established for either prostate cancer or CFS. Transfusion transmission is absolutely plausible based both on the WPI study, on some early primate work done primarily by the people at Abbott Diagnostics. There is no gold standard test at all now. The tests that are available are in the earliest stages of characterization and standardization. If you look at HIV as the model virus to which you want to compare XMRV, our level of concern is very high. There are a number of other viruses, and I'll name some of them a little later, that we had that same level of concern about early on, and it turned out not to be issues. There's very high interest from affinity groups like CFIDS and others. Canadian Blood Services, CBS, and the Australian and New Zealand National Red Crosses have already implemented passive deferrals of people with chronic fatigue syndrome. By passive deferral, I just want to be clear what I mean. None of these 3 blood authorities are in fact directly questioning donors about chronic fatigue syndrome. But when a donor provides the information that they carry a diagnosis of chronic fatigue syndrome, they're asked to defer at that time. So what are the scenarios? Unknown, unpredictable. These 3 viruses, the TTV-SEN group, a virus called GBV-C, and a retrovirus called simian foamy virus, raised considerable interest in the blood community as they were initially described. And while they are all plausibly transfusion transmitted, there are no disease associations with any of these. The first 2 were thought to be responsible for the residual cases of post-transfusion hepatitis that are seen subsequent to our implementation of sensitive HCV tests, proven not to be. Simian foamy virus is a monkey virus that does infect a few primate workers, but after long years of follow-up has no disease associations. So there's a concept that we're dealing with in the blood community now of kind of a normal viral flora. There are lots and lots of viruses that we can be infected with that cause no disease, and the need to intervene for those is limited. On the other hand, if one takes the doomsday approach, like HIV or HCV, a bad disease outcome with a long incubation period before you recognize that a donor or a potential donor is infected, that is spread by common routes of spread like sex. It may already be widespread in the donor population, and with a group of viruses like the retroviruses that tend to mutate quite easily and may change in their ability to cause disease over time, then you come up with a doomsday scenario for XMRV. We don't know which it's going to be, or something in between, and so we then began to examine what are the options for an interim intervention. Testing, none available. Deferral, well, as I pointed out, CFS and prostate cancer, for that matter, are surrogates of little predictive value if, in fact, 4% of the population is infected and completely well. They are, however, very low costs. We can defer donors who know they have CFS without a large quote-unquote cost in terms of the number of donors that we lose from a blood supply that can be quite tight at times. You can use passive deferrals, as I have described for CVS, Australia and New Zealand, or a more active deferral, which is what we have opted for at AABB, which is to provide pre-screening information, model materials to do so, versus a direct donor query in the donation booth, which from an operational standpoint is a much bigger deal in terms of SOPs, process, computer systems, and whatnot. Or we could do nothing while sorting out the science of the matter. Here's what we've done. This association bulletins come to the membership from AABB frequently. And in June, on the 18th, we told our membership that until further definitive data are available, we recommend that blood collection organizations make information available regarding the reasons why an individual with diagnosed CFS should not donate blood and components, and ask them to defer before they get into the screening booth. At my blood center, this is the language that we're using in a one-page, one-side handout to protect the safety of donors and blood recipients. There are reasons that people shouldn't donate, and CFS is an example that we've given now, and we are asking that those people who have been told by a healthcare professional that they have CFS lay out until we know more. And this is the actual language about XMRV. The model materials from AABB did not, in fact, by name, mention XMRV. I thought that was a little disingenuous. So at my center, we have elected to explain in as simple a language as I can come up with why. And here you see the language that we're using on a laminated handout that every donor sees as they come to the registration laptop at our fixed sites and our mobile blood drives. And then just to take it one step further into the future, Whitmore Peterson and Cirrus Corporation have already embarked on research to demonstrate that what we call pathogen reduction systems, that is chemicals added to blood that kill viruses and bacteria and parasites, will work as we expect it would on XMRV. That work has already been done, and the early work appears to be very positive. Obviously, it would be ideal if we were able to take every unit of donated blood, add safe and effective chemicals, and kill anything that we've missed, and in fact inactivate even viruses that we don't understand very clearly yet. This is several years away in the United States at least, based on the very complex medical and regulatory problems raised. So I hope everything's clear about where we're going with this now, and Kim, you can open it up to questions.
Just realized I had my mute button on. Can you hear me now?
Okay. I can.
I'm sorry. I was talking to myself, I guess, even worse than only looking like I'm talking to myself. I was saying there have been about 100 questions that have come in, and most of them were not ones I felt comfortable trying to address on my own. So I'm going to start with somebody who asked about the difference between FDA's regulations and the AABB standards that kind of govern the collection of blood in the United States at least, and how those two things obligate, like ABC and the Red Cross.
Right. The FDA regs, which are in two places, one in the Code of Federal Regulations, those are actual laws, and then in guidances that come from the FDA that aren't really laws, but if you are licensed and move blood in interstate commerce, functionally are just as stringent as laws. So at the end of the day, what the FDA says wins. The AABB standards reflect very closely what's in the regs. And the interesting thing about the standards is we're able to move much more quickly at AABB than the FDA is in terms of issuing regulations and guidance. So the AABB must reflect the current regs in a very real sense, but we're able to move the blood community more rapidly than is the FDA. So for example, our approach to XMRV in fact precedes any addressing of this issue by FDA. So they're complementary in that sense.
Good. Okay. And another question that's come up not only today but in other dialogue about the various countries and how they are responding to XMRV. Could you just briefly explain the difference between a deferral and a ban on donors that might meet certain criteria?
It's the same thing. Those are the same thing. I think ban is a kind of a loaded pejorative word, and I don't use it. We defer donors that do not meet our criteria, which can be more strict than the AABB standards, which can be more strict than the FDA. FDA and AABB, again, are minimum, and the current recommendation on XMRV is not yet a standard. It's a recommendation, and the standards program unit at AABB will be looking at this issue in the near future to decide if it needs to become an accreditation standard or not. AABB accreditation is not required to be a blood collection facility, but many, if not most of the hospitals we serve demand it as a prerequisite for a collection facility to provide their blood.
Okay, excellent. Looking here, there were a couple of questions. You mentioned this briefly at the end of your slide presentation about pathogen reduction methods and sterilization of blood. Are those techniques used in other countries outside of the United States?
They're beginning to be deployed. For example, there are 4 countries in the European Union that have approved methods for use in platelets. One is the INTERCEPT system that I referred to very briefly, and the other is called Mirasol. It's a technique that involves vitamin B2 added to blood. They're very expensive, and the regulatory approval process, not just in the U.S., but in the European Union and the rest of the world as well, is very, very complicated. Whatever we want to say about the dangers of blood transfusion, the safety of the U.S., Western European, and developed world's blood supplies now are really very, very remarkable, unbelievable in comparison to 30 or 40 years ago. And so anything that you add to a unit of blood has to be demonstrated in appropriately designed trials to be very, very safe before it will be done. It makes the regulatory timeline for something like pathogen reduction in the face of current blood safety a very long and winding road.
And kind of along those same lines, do other countries screen for the same viruses in the blood supply as the United States, or does that vary by country, just generally speaking?
The variation is, there's a little bit of variation, but not much. So, for example, rest of world or at least rest of world outside the Western Hemisphere, has not adopted a lot of Trypanosoma cruzi Chagas disease testing, for example. In parts of the European Union, donors are only tested once for HTLV, for example, and if they're negative one time, they're never tested again. But the basic menu, particularly HIV, HCV, and HBV, the AIDS virus, hepatitis B, and hepatitis C, are universal in the developed world.
To switch gears a little bit, there were a number of questions about blood transfusion in CFS, which would be the other end of the chain,
Right.
both about people who have CFS now who have a history of blood transfusion before they became ill, and also questions about whether there's any additional risk to people who have CFS now of getting a blood transfusion to their overall clinical health.
Yeah, the data set on whether people with chronic fatigue syndrome appear to have more transfusions than other people is not a robust data set yet. But what's out there suggests that people with a history of chronic fatigue syndrome probably have been transfused at about the rate we think the background population has been transfused. So over all these years before XMRV, nobody made an association between transfusion and developing chronic fatigue syndrome. And Kim and I actually were talking about this before the webinar started, and it just seems to us that if 4% of the donor base is in fact infected with XMRV, that we would have recognized some association in the past. One of the most important things that the XMRV Scientific Working Group will do is, once valid assays are available, do the complex epidemiologic studies as quickly as possible required to answer that question. The adverse effects of transfusion, the ones we really understand pretty clearly, are fairly discrete events, and it's not clear to me at all that we should expect CFS patients to do less well with transfusion than others. Now, having said that, when you can look at acute transfusion reactions and transfusion-transmitted infections and transfusion-related acute lung injury, and expect that CFS patients would be at similar risk. There are a very poorly characterized group of putative complications of transfusion that we're only beginning to investigate appropriately that go under a number of rubrics. One is immunomodulatory effects, and the other is, and I think more descriptive, pro-inflammatory effects of transfusion. And if, in fact, blood transfusion modulates the immune system significantly or causes an inflammatory state, there might be some rationale to expect that those manifestations would be easier to recognize or more commonly recognized in CFS patients. Totally speculative, no data, and it once again is going to be the kind of thing that will be answered only with a lot of work done after we have good assays.
We've talked about this issue too a little bit outside the webinar, but are there ways to go back and look at individual cases where someone has received a blood transfusion maybe many years ago to see whether that blood had any evidence of more newly discovered agents like XMRV?
Absolutely, and we do that every time that we add a new agent to our screening menu. So when HIV became an issue, and when we had a test and we identified current donors who were infected, we would do what's called a look back. That is, call the hospitals to which we distributed their prior donations, ask them to identify the recipients, ask then for those recipients to be analyzed for evidence of infection with the newly described and tested for virus. And those studies are already in design for XMRV should it turn out to be a rational thing to do. If we really believe that XMRV is causing illness, we have the ability to test current donors and, more importantly, to test what we call repositories that link donors and recipients. So we have samples, appropriately anonymized samples from the donor and the recipient of the donation, and if we identify then donors who are infected with XMRV in this example, we can go back to their donation, to their recipient samples, and try and see what's gone on, and then do what tracing is feasible depending on which repository is tested. So those things are all in very vigorous planning phases at the scientific working group, the NHLBI group, already thinking about those issues very, very clearly.
Good. Okay. Let's see. Another question here. Do you have your crystal ball with you this afternoon?
Only if I have plausible deniability.
Several people have asked how long you think it will be before there is a diagnostic test available for XMRV, both in the clinical setting and for the blood supply.
Well, diagnostic test, I think over the next 12 months, I think that assays will become available that can be used with appropriate caveats for diagnosis. Diagnostic tests and donor screening assays are distinct. They are different animals. Our donor screening assays are superb when they're licensed for diagnosis, are amongst the best ever developed. But most diagnostic assays are not up to snuff as donor screening assays. And if the consensus is that a donor screening assay is needed earlier rather than later, it's almost certainly going to be a DNA-based assay, PCR or TMA-based assay, because they're intrinsically, because of the nature of the technology, much more specific. From the time that West Nile was recognized as a threat to transfusion medicine until we were able to deploy nucleic acid or DNA-based testing was about a year. That took a Manhattan Project of really mammoth proportions to do that. That's the highest bar that can be set. We knew that we had an epidemic of a disease that was killing transfusion recipients, and we're able to get an investigational DNA test, RNA actually, in the case of West Nile, into blood centers in about a year. XMRV is going to take longer than that because the sense of urgency is not nearly as acute as it was for West Nile virus. More than a year is my best answer, and that depends on a lot of things that we don't know yet, like, is it important?
Oh, and a few people have written in about the possibility that XMRV lodges in other tissues besides the blood, which sort of takes it out of the topic of XMRV and blood safety, but you know, that's certainly based on studies of prostate cancer where it's being found in epithelial tissue, stromal tissue.
Although I'm not directly, I'm a little bit involved with the organ transplant community because I'm on the medical advisory committee of our regional organ procurement organization. But let me, cellular therapies, which AABB is involved with, are well represented in the groups that are thinking about this. So, I mean, all the way from semen to peripheral blood stem cells to regenerative medicine, we're thinking about this. On the organ transplant side, they're thinking about it as well. The stakes may be different than they are in blood. I mean, we can recruit healthy blood donors in substantial numbers and generally keep the blood supply good. I had this discussion with Harvey Klein the other day that when I need my new liver, I'm not as worried about XMRV as I am about the shortage of livers available. So it's a different set of discussions. The supply of organs life-saving, absolutely life-saving organs is so short these days that my suspicion is that that screening the organ supply is less of a priority than coming to an answer about what we should be doing with the blood supply.
Right. So that's sort of a to be continued topic.
Yeah. Yeah.
Yeah. Let me just do a couple more. If you have the time to stay with us for a couple more questions.
I have a little time, sure.
Okay. Okay. There have been a number of questions about the question that is asked typically at blood donation centers about, are you well today? And the difficulties that CFS presents, both from the standpoint of it being, in some individuals at least, a remitting relapsing pattern of symptoms. Also the fact that only about 20% of cases, at least by the last studies that have been done, are diagnosed in the clinical setting. So you've got a lot of people who might meet criteria, whichever criteria you want to use, that haven't yet been diagnosed by a physician and would not know to indicate otherwise on the donor information screening questions that are being used now. And then, of course, the issue that you raised with XMRV potentially being in asymptomatic individuals. And you know, just your thoughts on those three sort of challenges moving forward in terms of deferral policies and blood safety.
Yeah, I think that if you just look at the Lombardi paper, the Whitmore-Peterson Institute paper now, it's very, very clear. If that's true and the association's real and it's transfusion transmissible, questioning donors is not going to be adequate. The vast majority of people with the virus that we're interested in will be asymptomatic according to what they've told us. Now, that's hypothetical because it hasn't been confirmed and all of that. So, but in that setting, a test is really going to be the important approach. There's no sensitive, specific question that I can ask a donor that will eliminate the large majority of XMRV infections if 3.7% of the donor base is infected. There just isn't any. It's going to be a test issue. And as you can imagine, taking 4% or more of the donor base out because of a test result requires that we understand very clearly we're doing the right thing, because that's a hit. The blood supply is not always in a great position to take. And so I got 35 units in 1982 when I rolled my car, and I want the next time I roll my car for those 35 units to be available for me again. And so that's kind of the balance that we're trying to figure out at this point. But there is no sensitive, specific, highly predictive question that I can ask a donor if, in fact, 4% of normal individuals are infected with this virus.
Very good point. Let's see. Last one here is about methods other than blood transfusion as a possible vector for XMRV, and what the data indicates about sexual transmission, transmission from parent to child, between household contacts. What should people know about that as far as the knowledge base goes right now?
Well, I mean, basically we know nothing. Clearly, when you find a virus in the prostate, you ask about sexual transmission. It's reasonable to ask that, but nobody's demonstrated it, to my knowledge, with any kind of valid epidemiologic study that behavior X, Y, or Z is associated with XMRV infections. So we don't know. I think what we do know is that in one set of rhesus macaque studies done by Abbott Diagnostics and CDC and some others, that if you give the virus intravenously, if you give a laboratory strain of the virus intravenously to rhesus macaques, you can transmit the infection. That's what we know. And beyond that, we don't have a good animal model yet or anything else to explore other routes of transmission. Small German study that found the virus in respiratory secretions of a heterogeneous group of patients, and on and on and on. And the tissues in which the virus has been found in the monkey model are pretty diverse. So I'm sorry to keep saying more work is needed, but more work is needed.
The unfortunate thing about science, more work is needed.
Yeah, it doesn't move nearly fast enough for people who are interested in the outcome.
Okay. Well, I think we have exhausted your generosity at this point. There were literally a couple of hundred questions submitted over the last hour. So we have a very enthusiastic, engaged, and I think pretty knowledgeable audience from the questions that were asked, and we knew that going in.
Well, I think, Kim, if you can kind of classify them, you and I can shoot them back and forth, and we can write some short answers to the ones that are repeatedly asked. So
thank you, and you know, as we kind of said at the outset, the knowledge base is changing pretty rapidly. There is the first international XMRV workshop coming up in just a couple of weeks' time. I know that there is some data planned to be presented at that meeting about transfusion history and what we can say about the percentage of CFS patients who've donated blood since becoming ill that we have presented and will be given as a poster at that meeting. And according to what Bob Silverman indicated last week, there will be the plenary sessions plus about 20 other data presentations. So I think 3 weeks from now, you know, we'll have heard a whole lot more data about the evolving story of XMRV in both CFS, prostate cancer, and perhaps other disease associations. I'm going to take just a second and preview our upcoming webinars. We have another one this Thursday, switching gears completely over to the topic of Social Security disability, which remains a huge issue for many individuals who find themselves disabled to the point where they're no longer able to continue employment. And we have Max Sasser, who is a disability attorney and has held various leadership positions with the National Organization of Social Security Claimants Representatives, NOSCR, not NASCAR, but NOSCR, with us on Thursday for a webinar. And then just after the Labor Day holiday, we'll have Dr. Peter Rowe from Johns Hopkins University talking about orthostatic intolerance and how to manage the symptoms that often accompany that and are very common in CFS. And then about a month from now, exactly a month from now, Dr. Tony Komaroff from Harvard Medical School will give us an overview of CFS and the viral connection, which will include but not be limited to XMRV. And as I indicated, there's likely to be more data between now and September 16th that hopefully Dr. Komaroff will be able to include in his presentation. So we hope if this topic is of interest to you, you'll join us for that program as well. And you can find all the links to material that we've discussed today on our website, as well as the guidelines for safe blood donation that the association has put out, and include the AABB statements and other information about our webinars and the biobank on our website here. And we will follow up with an email message providing these links to you as well, because I know they're sometimes hard to pull off the webinar presentation. So thank you to everyone who participated this afternoon, especially to Dr. Katz for giving this presentation 1.5 times after we realized on Thursday that we weren't being heard by the rest of the audience. And the audience should know that he updated his slides each time we got ready to do this, so he's actually probably prepared for it more times than that. And should circumstances warrant, perhaps he'll join us again for an update. But we thank you so much. And many of the participants wrote in to the little chat box there to thank you for not only spending the time with us today, but for helping keep our blood supply safe. So I'll pass that on as well. And as we indicated, the recording will be up within the next day or two, and the slides will also be posted on our website, and we'll make those links available to you by email. So thanks again for helping us make the 11th webinar in our series a success, and we will talk to you all soon. Thanks very much. Have a good afternoon, evening, or rest of your day. Take care. Bye, Louie.